Thank you for joining us for this month's webinar with Denise Octavia Smith on the evolving role of community health workers as trusted messengers. Before we begin, let me cover a few logistics. The meeting will be recorded and will be shared. While our presenters are speaking, we will have our lines muted to reduce unnecessary noise. We will unmute at the end of the presentation for questions and comments. Please feel free to enter questions into the chat box throughout the presentation. Now let me turn it over to Kelly Rand.
Thanks so much, Kate. I want to thank everybody for joining us today, and I'm excited for us to have this conversation on the evolving role of community health workers as trusted messengers. I have with me today Denise Octavia Smith. She's the founding executive director of the National Association of Community Health Workers. And as a community health worker and healthcare administration professional, she designs and implements community-centered strategies to achieve equitable, diverse, and inclusive partnerships, programs, and environments. And prior to joining the National Association for Community Health Workers, Denise was a research associate and project manager at the Yukon Health Disparities Institute. She was a 2018 Robert Wood Johnson Culture of Health Leadership Fellow and a 2016 Universal Healthcare Foundation Leaders in Action Fellow, and one of my all-around favorite people. So I'm glad to welcome her here today.
Thank you, Kelly. It's good to see you. I would
So
say it's been a while, but we've been collaborating for the
one
last
of my
year.
favorite things to do.
Good to see you again. Thanks for having me.
So for context, I thought for those who don't know as much about the National Association of Community Health Workers, I thought we might start just with setting a little bit of background on your role as the founding executive director and why the organization was formed.
Yeah, thank you for that. I often go back to history to sort of go forward. So I think that's a wonderful question for me to start with. And I think, you know, what I want to say about the relevance of the National Association of CHWs, number one is that it was founded by community health workers, promotoras de salud, and community health representatives. And some may or may not be as familiar with sort of all of those phrases. The umbrella term is community health workers, but we're really calling up significant and very distinct communities and populations that have their own origin of a community health worker model, all now found in the United States. So when I talk about community health representatives, we're talking about CHWs from tribal nations. When I talk about promotoras or promotoras de salud, this is a different model that came from South and Central America and then was sort of found in the United States with migrant farm worker and immigration to the US. CHWs of an African-American tradition, we can trace back our origins to enslavement plantations, and those root workers, those healthcare providers who were using ancient African practices, pulling practices from indigenous nations, and also learning Western medicine and sort of binding all of those together to sustain and really preserve community health. And so, you know, I'm fortunate because all of these different communities came together with allies, individuals and organizations to found the National Association, because we as a workforce, didn't have an organization, a member-driven organization that was really lifting up the preferences, the expertise, the leadership of the workforce itself. We have lots of allies, right? From the Centers for Disease Control to the American Public Health Association to the Connecticut Health Foundation right here in my home state and many others. But we understood that while you can have local and state level organizing, it's wonderful to have a national association to be able to interface with other federal or national organizations and amplify the workforce. So I've been a CHW for over 20 years and was thrilled myself to hear that the organization had launched in April 2019. And then it was quite a moment to say, gee, I wonder if I could be the founding executive director. And I asked CHWs who are my mentors and my colleagues, should I take this on, and they said, why not you? You're a CHW, you've been doing this for 20 years. You certainly understand the issues on the ground, take that story to the national level. And so with the support of many others, I've been able to do so.
Wonderful. And so, as you've mentioned, community health workers have been around forever and have been an established role in health systems since the 1950s. But it seems their role has really started to grow and evolve in the past decade. Can you tell us a little bit more about what community health workers do now and the role that you and your organization are trying to carve out for community health workers?
Yeah, that answer is diverse as sort of the first one that I gave, but I appreciate you saying that. Notchwa, we were founded to unite community health workers across geography, across ethnicity, and across sector, so that we can together support communities to achieve health, equity, and social justice. And what's wonderful about that are, just sort of the evolving conversation that's taken place in the United States over the last 6 or 7 decades, which has sort of led us to this point, which is a recognition and acknowledgement that race and racism have impact on systems and policies, that those systems and policies impact communities, resources, power dynamic, access, and that those things impact biases, perhaps prejudices, barriers, financial, cultural, that can result in disparity, right, in health status and in health outcomes. And so there's been an evolving conversation in the US over these many decades of how we will address that. So I think about the Heckler Report in 1985 and how important that was to found the Office of Minority Health, and also to recognize that we need to begin to design and implement culturally appropriate healthcare interventions and services. Not too far before that time, as you mentioned, around the mid-50s, there was a recognition that tribal health, for instance, which was sort of codified in these very different treaties between the US government and tribal nations, which was supposed to guarantee access to health services, sort of wasn't overcoming now the barriers and the disparities in health status and health outcomes. So community health representatives came as an intervention that was born out of the culture to say, elevate the expertise, the trusting relationships, right? The shared language, the shared experience of these CHWs to intervene and support other healthcare providers and health systems to impact care. Many other interventions we find now in hospitals, in federally qualified health centers, in health plans, certainly throughout community-based organizations, which is where most CHWs work. And you'll find us, with upwards of 50 or so different titles. So you'll find us working in schools, perhaps as a parent liaison or a school liaison, helping a social worker, helping a school nurse. You can find us addressing the opioid epidemic or helping people access behavioral health services. Certainly with the passing of the ACA, many CHWs were in support of helping people enroll in health insurance, public or private. We're in a variety of different chronic disease programs that happen through departments of public health and local health departments or federally qualified health centers. And then increasingly, there are models being tested and developed to better integrate clinical and community partnership, which involves primary care, sort of centralizing primary care and connecting CHWs and the communities they represent, the communities they serve, to address prevention, right? Whether it's screenings, immunizations, well child appointments, vaccines, those sorts of things that are important to prevent the downstream impacts. Finally, I'll say, most of the traditions that I mentioned earlier all have a strong focus on advocacy and capacity building. And so when you see CHWs in these different environments, these different facilities with different employers, we also have the opportunity to really impact change in the organization by advocating and lifting up community needs and preferences to transform the way services are delivered.
And talking that really builds just off of what you talked about. Community health workers have really taken an active role in COVID-19, where there has been so many health equity issues, and engaging communities in things like their vaccine hesitancy or fears of getting tested. Can you talk a little bit about how COVID-19 has affected the role of the community health worker and some of the expanded duties that people have taken on because of the pandemic?
Yeah, would love to talk about that. So as I mentioned, our organization was founded in April 2019. I came on as the first ED in November 2019. And so this organization has largely grown up in the context of this pandemic. And it was very fortunate. While we all experienced our challenges, this was an opportunity for a national association to really amplify the roles of community health workers, to strengthen public health response, to strengthen the interventions of testing, contact tracing, expanded social needs screening and service delivery, and now, yes, to address vaccine access, medical mistrust, and obviously vaccine distribution. So we've been really active over the past year. We often think, we CHWs often think about our roles as transcending the sort of titles that we have. So if you step back for a moment, whether you're a liaison or an outreach worker or an enrollment assister, if you identify as a CHW, there are certain qualities and roles and skills that are part of your training and part of your calling, really. It's sort of why you are a CHW. Number one is that you have trusting relationships. And as we've seen during the pandemic, these trusting relationships are gold, right? They often make the difference between whether or not a person is going to get tested, whether or not a person is going to seek care, whether or not a person is going to sign up for a vaccine or pick up the phone of a contact tracer. Having people who are on the other end of that service or on the other end of that phone to introduce the service, to make it culturally appropriate and relevant to the environment. So if I call a household, I may know the family. I certainly know the lived experience. I understand some of the barriers that may be underlying that prevent people from sort of willingly wanting to access service. And so that is sort of a core function of CHWs, this cultural mediation and this liaison between different services through trust, through trusting relationships. There are many other components that are sort of natural to CHWs. I became a CHW, I started out as a teenager, really, and I had an elder in my family who was diagnosed with HIV. And I found that we were having very complicated conversations about HIV because it's a complicated conversation. And I found that there was something empowering in being able to take complicated information and break it down simply. And CHWs do that a lot. That's why we're called sort of bridge builders, liaisons, navigators, right? Coordinators, because sometimes systems or services don't talk to each other, particularly during the pandemic when lots of nonprofits in the early months had to close their doors. There were lots of employers who were trying to understand, how do we protect our own staff? How do we protect our clients? What services can we continue? What can we scale up? What should we bring to telehealth? What can we still do in person? While all of that was happening, a lot of CHW services were sort of shut down. And so it's really important to recognize, no, we need that connective tissue that CHWs bring. The ability to understand the housing, the behavioral health, the workforce, the food, the needs of a family or of a community. So that's another really valuable way that CHWs can lend to the design of different interventions during the COVID pandemic. They bring a cultural perspective. They understand a lot of the socioeconomic barriers because often we live in the same community. We might share the same disease state or survivorship, right? We have the same socioeconomic barriers. We may also have experienced racism in the system. So it's a way for us to speak of what we know and also work with the client to sort of help them, achieve their goals. Over the course of this pandemic year, and I know we just passed our first year, governors, national foundations, the World Health Organization, recently the Biden administration, sort of everyone is calling for a community-based workforce or CHWs. And I think it's important that people are grounded in the fact that not everyone is a CHW, that's really important. Everyone may desire to sort of take part in COVID, and we need an all hands on deck. But these very special and unique trusting relationships are cultivated over time. And I invite public and private institutions to find the CHWs who may be volunteering through your church, through your faith-based institution, a sorority, a cultural organization, right? Or who are employed at the nonprofits or immigration advocacy organizations or FQHCs in your community, because those are the folks who are going to be the right messenger for these very difficult conversations that we're having these days.
Great. And that also builds into my next sort of set of questions. You referred to our working together, and the project that we're working on is looking at how community health workers build trust. And we're looking through it through the lens of choosing wisely, but also trying to dig deeper into how those relationships are formed, what training is needed, what things could be applied to help grow and build this community of community health workers. Could you talk a little bit about this project and what you've learned so far?
Yeah, happy to. And again, this is also a project that I guess has been brewing for a number of years. As a CHW, before coming to the National Association, really even before coming, working at UConn, when I was working on ACA enrollment through our state marketplace in Connecticut, I heard about Choosing Wisely. I venture to say, if Nancy Yedlin and the Donahue Foundation is on the phone, I heard about Choosing Wisely through the Connecticut Choosing Wisely Collaborative and their work and support of this larger initiative. And it was interesting because I also identify as a patient. I'm a survivor of a rare chronic disease. And so I cared very much about these conversations that I think Choosing Wisely was lifting up. But as a CHW, I really hadn't heard about the connection between Choosing Wisely and the relationships and the conversations that community health workers have with their clients who are also patients, right? Who are also seeking health-related services. So I want to say that I've tried to weave Choosing Wisely conversations in all the work that I've been doing over those many years around health insurance literacy and health services navigation. Now, in my role at the National Association, I have a chance to bring this conversation to the national level and make more community health workers aware. And so I just want to give a shout out to the Donahue Foundation, again, in my home state of Connecticut, who, because of our prior relationship and hopefully my commitment to Choosing Wisely, sort of asked, would you be willing to take some of the learning of the Connecticut Choosing Wisely Collaborative, bring that to the national level? And I said, yes, if I can do it with Kelly, yes, if I can have some good partners to support me. So we recruited about 12 CHWs and a couple of what I would call patient advocates, the Connecticut Center for Patient Safety, Umemba Health, and a couple of other organizations to begin a conversation about the ways in which community health workers build trust, the environments where they build trust, and how they can integrate conversations, not just the choosing wisely questions, but really the strategies and some of the other tools and resources into their daily practice, right? Again, working across sector, working in different environments. How is this conversation relevant? And I really think it is. And our team of CHWs also thinks it is. So we're working on a couple of different fronts right now. We've been looking over the Choosing Wisely set of materials. And what we're hoping to do is sort of map those materials that have already been created and established and figure out through our team of CHWs, you know, how would you use this brochure? How would you use this training? You know, how would you use this video? Understanding that the materials may not have been made for CHWs, but in what ways are they similar to your existing role? You know, does it make sense for you to integrate this into your outreach? Or when you're working on a care team and you're with nurses and doctors and social workers, is it appropriate to sort of bring up these tools and resources? How can you strengthen the capacity of your clients when they go to their appointments to be prepared to have this conversation about cost, about treatment, about harm, about low and high value care? And so the team that we have is really excited. I want to say we're going to do a bit of research too. So in addition to pulling some materials together to build a web page that will be available for CHWs across the country, we're also doing a focus group with patients and with CHWs to dig a little more deeper on these pathways, on the ways in which trust and communication is built, and how, again, we can understand it better so that we can have better conversations.
Yeah, just to follow that up a little bit, I think one of the mind-opening conversations you and I had when we were talking about this is that, you know, it's sort of assumed that community health workers have a trusting place in the community. But when we tried to dig into it, there wasn't a whole lot of research on how or why or so are there any, I guess, very early emerging themes that you think you're hearing from some of these conversations? I'll just throw out one that I think stood out the most from the first meeting for me was sort of the shared experience that every single community health worker had their own story of having a health issue or caring for somebody with a health issue, and then just meeting barrier after barrier. I mean, at least for me, it was a very emotional experience to hear why they had chosen to be community health workers. Can you talk a little bit about what you think are some of the things that are starting to bubble up?
Yeah, I remember that first meeting that we had in December, and you're right, it was incredibly moving because we called CHWs in really to talk about their role as CHWs and to have them, so many of them, identify as patients, as survivors, and really bring their level of trust to lived experience, right? Not just culture, not just language, not just shared geography, but to say, yes, one of the reasons that I am a CHW is because I had to live through an experience, and I have sort of a calling, to want to give back. I've learned so much because of my experience, that I'm turning back. And I think we have that in many of our communities. There's that person that who sort of willingly, seeks out information and shares it with others through a women's group or a men's department ministry or through social media. There are those people who just have a calling to make sure that you sort of get what you need to be well. But to have this added lived experience I think is really going to help us even dig deeper into these choosing wisely materials. You're right, there's not a whole lot written. And it's fascinating because even the definition that many states or many researchers, when they refer to CHWs, when they refer to the APHA definition, it says that they're trusted. You know, it's sort of right there in the very first sentence, but we don't really know what establishes that trust. You know, is it trust built over time? The reasons that I think someone might trust me are not necessarily the reasons that they end up trusting me, right? Maybe they're looking for something else. Maybe that patient, that client is looking for something else other than just our shared ethnicity, our shared geography, our shared language. So it can be many things. And we're going to be exploring it, you know, over the course of these next couple of meetings, so that we have some science, right? Some evidence to bring forward, albeit qualitative, but I think it will be really important and instructive for all sorts of providers and systems who want to work better with CHWs. Because a lot of folks ask, you know, why can't a case manager do that? Or why can't a social worker do that? Why can't a nurse do that? And all of us are doing many things, right? All of us ideally working at our highest sort of scope of work. What is it that is unique to CHWs? We know that it is unique because over these last 50 or 60 years, CHWs are often hired into interventions because the researchers or providers know that there is community trust. But we just don't necessarily know what drives all of that. And so I think that's what we are exploring more deeply. But certainly most of the CHWs that I've met that have mentored me and the ones that I've met across the country all have a deep sharing between them and the families or communities that they serve.
Great. And thinking about organizations that want to work with community health workers, and there may be, I'm hoping there are ones on the webinar now. I guess one of the things that I would ask are, what are some practical steps to engage community health workers? And something I've heard, I guess, from a number of people is that they might occasionally work with community health workers, but it's not an extended relationship. So what else needs to happen to, you know, maintain a relationship with a community health worker or community health worker organization?
Yeah, that's a fantastic question. A lot of that unsustained relationship is sort of based around funding, more often than not, because I think when authentic partnerships form, and when CHWs are able to contribute meaningfully to your teams, to your intervention design, to your implementation, I think their value becomes apparent. But a lot of times it's just, you know, the grant period has sort of run out, kind of thing. And so we're obviously waiting and advocating for sustainability in many different forms to occur. So a couple of things I'll just sort of say in the meantime. During this very active legislative session at the federal level, you will hear a lot about community health workers. And some of those policies, some of that legislation may impact your states, right? There may be funding that comes to your state for health departments, local or state level, or hospitals or FQHCs to hire CHWs, to partner with CHWs. One of the first things that you can do is look for your local or state-based CHW association. So some states are so large, like in Houston, they have their own CHW association for the city of Houston because of their size. But in Connecticut, we have one that sort of covers the entire state, right? So look to that CHW association or network as your partner. If you don't have an existing partnership, you know, don't wait until there's an emergency, but start to develop that relationship now to understand what are the best practices in training, who is being brought in and sort of networked as community health workers now in the association. Where do they work? Where do they serve? What are their experiences? What are their levels of expertise? be it language, shared experience. Some of them have done research. Some of them are diabetes educators. There can be a host of sort of different skill sets that are brought to that work. If you have trouble finding your network or association, the National Association website, we have a listing of training sites across the country, organizations that train CHWs, as well as association, sort of member-driven organizations for CHWs. Then there are also on our website, as well as others, some good guiding policies to partner with community health workers. A lot of those come from the American Public Health Association, starting in 2001, where they really just sort of acknowledged our role to address disparity and to promote equity. There are further policies that urge public and private institutions to reimburse CHWs and to develop sustainability models at the state level. And then also in 2014, they put out another policy talking about the shared decision-making and really centering the leadership of CHWs, remembering that we also are professionals, right? This is our profession. And so we want to be not just a downstream implementer of an intervention that's already been created. We want to be a part of the thinking, the theory of change, the intervention design, the research questions, the tools. When you do that, what you're doing is you're centering the voice of the CHW throughout your intervention sort of life cycle, but you're also lifting up the voices of the communities that CHW represents, because they have a chance to bring that knowledge and that expertise to tailor and inform your design. And particularly during COVID, that has made a lot of the difference. As I look across the country, organizations that were doing contact tracing, when they hired sort of just anybody who wanted to do contact tracing, they found barriers, right? When they centered some sort of community-based workforce, a nonprofit, volunteers, whoever they were, who were trusted in the community, they had an easier time traversing the difficult conversations to get to service delivery. And so there are some best practices. NACHWA, we have some tools if people are interested in recruiting and hiring CHWs. How do you do that? We have a playbook on our website and other resources that I'd be happy to share.
Sure, we should put your website in the chat, Kate, if you wouldn't mind doing that.
Yeah, I'll throw that in now.
Oh, perfect. And we're starting to get some activity in the chat. So let me just start on some of the questions from them, and I'll put my last questions aside and let everybody else get a chance to have this conversation with us. Nancy Yedlin is on the call, and thanks for the shout out. Daniel asks, what drives trust for community health workers?
In other words, our trust of others or others' trust of us?
Daniel, do you have a answer?
Your patients trust in you and your trust in them, both ways.
Yeah. Yeah, that's an interesting question. So, how can I answer that sort of quickly? As I think back to all of the different programs that I've worked in as a CHW, an HIV outreach worker, heart disease and stroke, community violence prevention, health insurance literacy and enrollment, right? As a CHW, you move through different programs based on the grant funding, or because a lot of this funding so far is short term. But there has been a couple of threads for all of that for me, and I venture to say for most CHWs, right? Unless you're moving, out of your community for a job. Part of that is where your voice is similar to the voice of your clients and your family. CHWs, our model is to build capacity. It is to accompany, right? It's to come alongside. Phrases like shared decision-making, right? Authentic partnership. These are givens for community health workers. Our service is really to help people achieve their goals, right? Their health and well-being goals. And the fact that we can offer specific services from a hospital or from a nonprofit is sort of an add-on, right? But oftentimes we provide services that we're not funded to provide. So if I go to someone's house and I'm focusing on heart disease and stroke prevention, and so I'm sort of talking about knowing your numbers and, you know, talking about diabetes and smoking and that sort of thing, but people tell me that they don't have access to healthy food. I know that even though I'm not funded to provide those services, it is my calling, it's my responsibility to begin to address those barriers. Now, that might mean I connect to another CHW I know who's working in nutrition and food insecurity programs, or that might mean I spend time on the phone calling around to food pantries and soup kitchens until we have some good solutions. But all of that is to remove the barrier so that that person can focus on preventing heart disease and stroke, right? So we're sharing in the plan, we're sharing in the goals. And so I don't say that I know what's best. I say, here's what I know. And then I also say, I know that you know a lot too. You can help me help you better than I can trying to figure out on my own. As I mentioned earlier, you know, there's not a whole lot of science that's been documented on the ways in which why it is that patients trust CHWs. And not all CHWs identify with people who provide services for people who identify as patients. So that might be in a clinical sort of setting or with primary care or specialty care, but CHWs are doing community-based work too. But I think that you know is what I want to say, is that you know when someone trusts you. There's something that begins to happen, and the feedback is it is between both of us. I'm teaching and learning, you're teaching and learning. And we really become much more like friends. You know, I'm not coming to necessarily deliver services. I'm coming to check in on someone I care about. And when I used to do home visits, and that was a very intimate setting, people knew that, you know, maybe not the first time, because they wondered, what kind of data are you going to collect? You know, what sort of intake form? How, you know, do I have to pay for this service? What if my insurance doesn't cover it? People have all sorts of thoughts about how things are going to go. And your ability to sort of read those concerns, to probe for those concerns and remove those so that you can just start building together. I find that that people want, you know, they want to share that space, like a shared space of health and well-being. You know, I think everyone wants to go on and live the life they were meant to live, whatever that is for them. And the things that are barriers are so draining on us that it's nice to have someone who is not going to sort of shame you for that, someone who's not going to burden you with a lot of paperwork, someone who's going to recognize that it's hard. It's hard sometimes to achieve health and well-being. But when I want to do it, like, I'd love to have a partner in that. And that's who CHWs are. I mean, patients and family members, they also see us advocating. So they also get a chance to observe us in different settings, saying, this is what Mrs. Smith wants. You know, this is what Mrs. Smith is asking for, and I'm not sure that you're hearing her. So sometimes they get to see us in that space. And it's nice to know that, yeah, someone's in your corner. You know, sometimes if I'm a patient and I'm dealing with a disease or I've got to navigate services, I'm exhausted. You know, I'm stressed out already, you know, and I'm worried perhaps about my family, my finances, my own health and well-being. Oh my gosh, it's so nice that there's someone who I can trust to lift up my questions and concerns, and then check with me to make sure, like, is this going well? I think someone put caring and compassion. Yes, and I think we all have that. but CHWs, you know, that's what we lead with. That's our currency.
Talking about currency from a different perspective, one of the questions in the chat is, how does payment work for community health workers? And you mentioned grants, but is there reimbursement in some states? Does it vary across the country?
Yes to all of those. Yes to grants, yes to reimbursement in some states, yes to many emerging models. So something else I can throw into the chat is a report that NACHWA put out, I believe it was June of 2020. It seems like a long time ago, around sustainable financing models for CHWs. And what that does is really look over the last 15 years or so, the different ways that CHW programs and services have been funded. And it sort of talks about the strengths and challenges in many of those. Let me start at the beginning to say the majority of CHWs are still working in community through nonprofit organizations. And most of the time that is grant funding, right? Every now and then a nonprofit gets a contract, a sort of multi-year contract for services, but most of it is grant funding for a term, you know, a year, 2 years, 3 years. There are certainly states across the country that are advancing Medicaid reimbursement. That's exciting, but of course, what NACHWA and others are tracking is the scope of those services. So, you know, as I mentioned earlier, there are a host, a sort of a cohort of our roles and skills that we bring as CHWs, in terms of who we are as professionals. And sometimes employers will ask us to only do 1 or 2 of those things. You know, I just want you to do outreach, sort of, that's it. And maybe that's because that's what they can be clearly and easily reimbursed for. We're learning, we meaning health systems and health advocates, understand that that doesn't really translate to addressing inequity, right? And achieving well-being for people, right? If you want to eliminate disparity, you sort of have to meet people where they are and meet the needs of the community or the population. So when you limit the services, sometimes you get a limited output and a limited outcome, you know? And so we're encouraging people to think broadly about the way in which they are designing the Medicaid sort of cohort of services that talk about prevention, that talk about community and home-based visits, that talk about care coordination and cultural mediation. And I can also throw in, like I said, some tools and resources around the National Core Consensus Project. If people don't really know what are the roles of CHWs, right? What are their competencies? What does their training give them as a skill set? That is good guidance, along with the APHA policies and others, to design good programs. There is some funding that comes through state health departments, through 1815 grants and others. Sometimes it comes in the way of, as I mentioned, grants and contracts for specific service, but increasingly, state health departments are taking some of that money to build the infrastructure of CHWs, right? To make sure that they have a professional identity, to make sure that they can develop partnerships and relationships and create awareness around their workforce. The further we get into pursuing equity and social justice, the more we're going to want this workforce to be integrated into our operating budgets, right? More integrated into our long-term strategy. And whether that's through Medicaid or whether health plans hire CHWs to address housing and transportation and, you know, a host of other sort of social needs screenings, you know, we'll continue to build awareness until that happens.
And we have someone from a state health department, our own physician consultant, Lisa Letourneau, who I think could add a little bit of state perspective.
Yeah, great. Thanks, Kelly, and thanks, Denise, for a great overview of that. I just wanted to chime in behind some of your comments to say, you know, I think there's been a lot of interest in saying, well, let's just pay for the services. Let's just get Medicaid agencies to pay for it. And as Kelly mentioned, with full disclosure, I also serve as a senior advisor for the Department of Health and Human Services in Maine. And we're very interested in how to create a sustainable funding program for CHWs. And as you're saying, I think it's really going to need to end up being a blended model, because what we don't really want to do is recreate the problems of the fee-for-service system for community health workers, right? Like, what exactly are you paying for? Oh, 10 minutes here and 5 minutes there, but not that thing and not this thing. Like, it's just almost, fee-for-service system is almost antithetical to the whole purpose and mission of community health workers, as you've so beautifully been describing. So with no, certainly no criticism of states that have done that, and certainly trying to find it, we just worry in Maine that using that as a primary solution is not going to support CHWs in the way we'd like. So what we're talking about is really a combination of things, as you said. So some of the 1815, what block funding or block grant funding could states get and dedicate to infrastructure, combined with other grants certainly that come up, but not grants only, because right, those come and go, and then you lose the funding, and there goes that program. And then we're talking about also building it into our value-based payment program for primary care, where we have different levels of primary care. And I think it's the second level. If practices say we are employing a community health worker, they get a higher population-based payment per month to help support those services, which then frees them to use those services in the way that makes the most sense and not tied again to this 10 minutes or 15 minutes or this service or that. So I think it's tricky, but I think it's doable, and we need to figure it out. I think there's also some great work going on through organizations like yours and the Penn Center for CHWs, right, that are talking about, how to create sustainable funding models. So we just encourage people to think broadly about that. Thanks.
Yeah, I appreciate those comments. I'll just build on something that I think is really important, that we're getting sort of anecdotal evidence now during the pandemic that I think is really important, and it's about the strategies, the evidence-based strategies, the best case examples of integrating CHWs into larger health systems or service delivery, and where CHWs are placed is really critical to their scope of work, sort of who determines the battery of services that they provide, their autonomy and their agency to really be driven by the needs of the community and the population. I think, I'll give you another sort of short example and then sort of move to my point, which is, there were a number of contact tracing efforts that involved, folks sort of cold calling families, right? And trying to connect them to testing, or, giving them sort of skill sets to socially distance at home and all these sorts of things. And I think one of the challenges when CHWs were hired for contact tracing initiatives, and many of them were across the country, oftentimes those contract tracing initiative programs didn't allow CHWs to respond to the needs that presented over the phone. So just imagine calling someone's home and they've been home for 5 weeks. Their 3 kids have been home for 5 weeks. They've left their jobs so that they can take care of their 3 elementary school children and help them get on Zoom and help them, take their classes. Now they have, incredible needs, not only for technology, but now 3-4 meals a day are being eaten at home by every adult. There's a lot of stress and anxiety and concern on the phone. And a number of CHWs that I spoke to, I'm thinking of a state in particular, but I just don't want to name it, actually left the contact tracing initiative because they were told sort of not to document some of these requests, these housing insecurity requests, these food insecurity requests, because they said, well, that's sort of not your scope. It's not what you do. But it's what CHWs do, right? It's what we do as a profession. And so I think, Lisa is absolutely right to say we need to translate that holistic nature of service, that cohort of service, to the funding, right? Not just for fee for service, but for a value, right? And that the value is that that family, that individual achieves their health and well-being, that they prevent disease and they are pursuing and achieving their health goals. Similarly, we have to do that for CHWs, for their scope of work. We have to make sure that the interventions are not so discrete, right? That we limit their ability to address some of these barriers. Because as I mentioned before, I, as a CHW, would often do this informally. No one ever asked me to collect the data on all the other services that I was providing on my own time, sitting at home or sitting in my car, calling a shelter or calling a food pantry or connecting someone to another CHW who I knew. But this is valuable data. And so again, I urge people to invite CHWs to the table in the design, in your technology design. Where is the data? Where do we collect information? Because if you want to know what you can reimburse for, ask CHWs all of the services that they provide, all of what they actually do to address the needs of a family. And I think people will find that there's a lot. There's a lot going on. And so there's a lot of opportunity to make the case, right? To make the case for our value.
Great.
Thank you so much, Denise. I want to be respectful that you told me you have to leave at 4:50. We do have a couple of questions that are still left in the chat, but can I send them to you and we can send those answers out to the group? Since I know you do have to leave, and I'm sure we could probably talk to you for another hour. But if I can send you those, we can send them out to the participants here today.
Okay.
And I just want to thank you so much for joining us today. Such a wonderful presentation of such, empowering and wonderful work that you're doing.
Kelly, thank you so much. It's been, as you know, a pleasure working beside you. And I'm so glad that our paths continue to cross. I want to thank ABIMF again. I consider Daniel a friend as well as a colleague, and I'm grateful for the leadership of this organization, continuing to evolve and deepen the conversation that is so really important, right? So thank you for, pursuing trust and equity in everything that you do.
Thank you. And now I'm gonna turn it over to Kate to close us out.
Thank you everyone for coming today. Please join us on Tuesday, March 16th for our webinar on tools for building institutional trust with our speaker, Jennifer Stevens from America's Essential Hospitals.
Thanks
Thank you.
everyone so much for joining us today.